Robertson. This is a quick little presentation I put together about shock at the EMT level. This is also my 15-minute video for instructor methodology, so I'll go ahead and get into slideshow mode here and we'll get started. Alright, so a little bit about me before we get started. I've been an EMT for about 3 years. I'm taking this class because I had some unfortunate circumstances happen where I had knee surgery and I've had to get off the truck for a little while, so I'm hoping to hopefully teach the next generation of EMTs coming up. So we'll get into it here. What is shock? So shock is a state of cellular and tissue hypoxia due to either reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of all of these. And we'll see all 4 of those in each of the types of shock that we're going to go over here today. Simply put, that means the cells in the body are not getting enough oxygen and nutrients to function properly. So if the cells aren't getting enough nutrients and oxygen from the blood flow, then obviously the body's not going to function the way it needs to be, and that's going to lead to shock. So why do we care about shock? Why is it important? Obviously, I think most of us know that shock is life-threatening. It does require immediate attention, though. I mean, if even 5 to 10 minutes go by, shock can go downhill really fast. And as I was just saying, delays in treatment can cause shock to get worse really quickly. So immediate treatment and immediate transport is going to be key. Just because there's not too much we can do in the field, but we're going to do what we can and get them to the hospital as quickly as possible. Types of shock. There's several different types of shock, but there's about 4 we're going to go over today. And in one of those 4, there's 3 subdivisions. So all in all, there's about 7 types of shock that we're going to go over today. I've got a little mnemonic here. I know some people learn well with that. So we've got a little mnemonic here with the 9 types of shock. Like I said, we're going to go over 7 today. I think one of the ones we're going over is not listed here. But this is still a handy tool to use. I know some people love mnemonics, so this one's going to be shrimp can. So it's going to be 9 types of shock. It's going to be septic, hypovolemic, respiratory, ingestion, metabolic, psychiatric, cardiogenic, anaphylactic, and neurogenic. Like I said, we're going to go over a few of those today. We're going to skip over some of them. Let's see, we're going to skip over ingestion, metabolic, psychiatric today, and respiratory. And I believe one of them we're going to go over is not listed, but we'll get into that in a second. There's the types we're going to go over today. We got hypovolemic, cardiogenic, distributive, and obstructive. And then within distributive, there's a few subcategories, like I was saying earlier, with septic, anaphylactic, and neurogenic. And we'll dive into each of these in depth. So we'll go into hypovolemic first. So hypovolemic is going to be due to severe hypovolemia. For those of you that don't know what that means, hypovolemia, just simply put, there's not enough volume in the body. So whether it be fluid, blood, stuff like that. Easy way to remember this, hypo means low, and then volemic, volume, so low volume. I don't know if you can see my cursor here, but low volume. As I was saying, it's going to be caused by a loss of blood or fluid, and the reduced blood volume is going to lead to decreased cardiac output. So if there's not enough blood, the heart's not going to be able to pump as effectively, and it's not going to be able to perfuse the body as well. So a few symptoms with that: rapid pulse, tachycardia. The body's going to be trying its best to keep up with the reduced blood volume, so the heart's going to be pumping. Heart's going to be working overtime trying to keep up with the reduced blood volume. And with the low blood pressure, again, with the low volume, there's not enough volume to fill those vessels. So the blood pressure is going to be low here. And we're going to also have cold, clammy skin. The body's not going to be getting perfused the way it needs to be. So the extremities are not going to get the amount of blood that they need. You also may see some confusion here with hypovolemic shock. Again, the brain's not getting perfused properly. It's not going to be working properly. It's going to lead to some confusion in some patients. And we will get into treatment more later, but that's just a quick overview. And then cardiogenic shock. So again, heart not pumping effectively. Again, an easy way to remember this. Heart, cardio, pretty simple, pretty easy to remember. When the heart can't pump enough blood to the brain and other organs, that can lead to cardiogenic shock. Some symptoms of this: chest pain, again, rapid pulse. Heart's going to be working overtime trying to keep up and perfuse the body the way it needs to. The pulse is going to be weak and thready, though, so you're going to feel that, but it is going to be rapid. You're going to have shortness of breath, and then the extremities are going to be cold. That's going to be, again, due to those extremities not getting enough blood, so they're going to be cold. We'll get into distributive shock here. That's the one with the 3 subtypes. You can see those 3 subtypes listed there. We've got septic, anaphylactic, and neurogenic. All 3 of those, though, are going to be caused by vasodilation. So when the vessels are dilated, they're getting too big, and the blood is not creating enough pressure in there, so that you're going to have low blood pressure as your symptoms. And the symptoms do vary by the subtype, but in most of them, you're going to see warm and flushed skin in the early stages. And we will get into those subtypes now. So we've got septic shock. That's going to be caused by an infection in the body that is just out of control. So usually when we see infection in the body is able to kill off that infection and control it properly. But with this, the body's going to have an improper response to that infection, and it is just going to run rampant in the body, and the infection is just going to get worse and worse and worse until it leads to septic shock. The symptoms with this, again, low blood pressure, like I was saying, because of the vasodilation, rapid heart rate, and a fever. The fever is because the body's going to be getting warm to try and fight off that infection. Like you see with maybe if you have a cold or a flu, you might have a little bit of a fever. This is just going to be a severe fever that you're not going to see any kind of mild fever. So many agencies are going to have a certain protocol in place for sepsis alert just so it doesn't get used when it shouldn't be used. We're going to need to see all 3 present in order to be able to classify a patient as septic. You're going to need a systolic blood pressure less than 110. You're going to need a heart rate greater than 90 and a respiratory rate greater than 90. So if you have all those 3 present, then you're going to need one of these. Again, we've got another mnemonic here, batons. A systolic blood pressure less than 90, an age greater than or equal to 40, a high temperature. I know that's in Celsius, but that can be converted to Fahrenheit. Lower than 90% oxygen saturation. A nursing home, we can see infection run rampant in nursing homes. When one person catches it, it seems like everyone's going to go ahead and catch it. And then if they're classified as a sick person on the call, one of those and then all 3 of these, then you can call sepsis on a patient, and you can alert the hospital that we've got a sepsis patient coming in. And then some exclusion criteria here you can see on the right side. Age less than 18, trauma, cardiac arrest, pregnancy, psych, toxic ingestion. A lot of those, you're going to see some similar symptoms, and some of them are just a lot more urgent than sepsis, mainly cardiac arrest. Anaphylactic. So anaphylactic you're going to see, I can almost guarantee you will see in the field. Very, very common, especially in children. It's a life-threatening allergic reaction, so people with allergies know that if they get to this point in their allergic reaction, it is not good, and it can lead to life threats. Like I was saying, it's one of the more common forms of shock. Symptoms are going to be swelling, hives, breathing difficulty. So that breathing difficulty is going to be because the airway is going to swell a lot of times. So you're going to see a lot of swollen airways, and that's going to be the main thing you need to get under control before that throat closes up and the patient's unable to breathe. Neurogenic shock, the last subtype from distributive here. Neurogenic is going to be caused by a disruption of autonomic nervous system pathways. So that's going to happen after damage to the brain or to the spinal cord. The body's going to have trouble maintaining homeostasis. For those that don't know what that means, that's the body's equilibrium. So the body maintaining a proper heart rate, a proper temperature, and a proper blood pressure. Because of the damage to the brain, the body's going to almost freak out in a way and not know what to do and not know how to maintain that homeostasis. Symptoms with this are going to be bradycardia, low blood pressure, and AMS. Again, for those that don't know what that means, that's altered mental status, so you're going to see some confusion here with neurogenic shock. So we'll move out of distributive now, and we'll go into obstructive shock. So again, another easy one to remember, obstructive, obstruction, obstructive. Very easy to remember, very simple. A lot of these names are straightforward and to the point. Obstructive shock is going to be caused by an obstruction, like I was just saying. So there's going to be a clot somewhere that is obstructing blood flow. That's obviously going to lead to a decrease in circulation. Symptoms of that are going to be tachycardia, hypotension, and JVD. I have some pictures here for those that may have never seen JVD. You can see the jugular vein there. JVD is jugular vein distension, for those of you that do not know. You can see the jugular vein there is poking out really, really well. Well, not well, but you can clearly see it. So, recognizing shock, I just talked about some symptoms and maybe some vital signs that you may see with shock. So if you see any of those, it's almost a pretty safe bet that you're going to have some kind of shock patient. Like I was saying, many of the vital signs are consistent. Again, like I was saying, hypotension, tachycardia, those are two very common symptoms with shock. And obviously, this can be other things, but if you see hypotension and tachycardia along with some of the other symptoms we talk about, it's more than likely going to be a shock patient. Skin signs, skin's going to be pale, cool, clammy. Again, that's going to be due to the poor perfusion from the heart, so that the skin and the extremities are not going to get enough blood. So they're going to be pale and cool. And increased respiratory rate as well. That's going to be the body's response to not getting enough oxygen, like we talked about in the first slide. Ultimately, this all boils down to oxygen. So the body's going to respond to that by increasing the respiratory rate. Patients are going to breathe really rapidly to try and take in more oxygen and take in that extra oxygen so that they can try and keep up with everything that's going on in the body. So some general treatment before we get into the specifics. Obviously, you're going to work on your ABCs first. Airway, breathing, circulation. Those are key in any patient, but here especially with anaphylaxis, you really got to make sure that airway is open. But you want to ensure that the patient has an open airway, and you want to focus on improving circulation if you can, whether that's warming the patient or just doing anything you can to get their circulation back. And then after you take care of the ABCs, you're going to move into your specific treatments. So we'll get into that now. So for hypovolemic shock, you really want to control bleeding. If they're losing a lot of blood, you want to control the bleeding, whether that's applying a tourniquet or putting some kind of dressing on or just holding direct pressure onto that wound. You really want to stop the bleeding. It's also not a bad idea to call for an ALS level truck just to get some fluid in there to replace some of the volume that was lost. That can help to raise blood pressure and also help to improve other symptoms of hypovolemic shock. So for cardiogenic shock, the biggest thing is going to be rapid transport. You want to get those patients out of there into a hospital quick, because ultimately they don't need anything we can do for them. They need a hospital. So you want to get them out of there as fast as possible. Something that I was always taught coming through EMT school is time is muscle. So as time goes on, the heart will continue to lose muscle and continue to deteriorate. So you want to move really quick here. And the more time you spend on scene, the higher chance you have of death or irreversible effects. So you really, really, really want to get out of there and get to a hospital. While you're performing that transport, though, it's important to give oxygen and position the patient comfortably. So the patient might have some chest pain. You want to position them in a position of comfort to make sure that it's going to be as comfortable as possible for them. And you want to also give them some oxygen. Again, like I said, the body's going to be breathing really heavy to try and keep up and try and replace some of the lost oxygen. So you want to give them a little extra oxygen to help out with that. Distributive shock, again, we've got our three subtypes there. Septic shock, you want to transport rapidly. Again, not a whole lot we can do for them, so they need a hospital more than anything. And then, again, ALS, you might want to call an ALS truck because they can administer some fluids. Neurogenic shock, you want to keep the patient warm, as I was saying. The body's not going to be perfusing properly, so the patient's going to be really cool. So you want to keep them warm, whether it's blankets, turn the heat up in the truck, anything you can do to keep them warm. And then anaphylactic shock we'll really harp on just because of how common it is and how likely you are to see it. You want to go down the anaphylaxis protocol, which I have a picture of next slide for anyone that has not seen it before. You're going to want to give epinephrine. A lot of patients are going to have their own EpiPen, especially if they know that they're allergic to something, whether it be bees, tree nuts, shellfish, something like that. But sometimes patients might not have their own epinephrine, and you're going to give them yours, and that's okay too. Again, you want to administer oxygen, and then you want to use albuterol or Benadryl if indicated, which I believe Benadryl is indicated in the protocol, and then albuterol you want to give if you hear any wheezing in the lungs, so you want to make sure you listen to lung sounds. Here's the protocol. So this left column, that's not really anaphylactic shock, that's just skin. That's just going to be hives, a breakout from something. That's not going to be anything too life-threatening. But this column here in the middle and this column on the right are the ones that can be life-threatening if they go untreated. So again, we're going to be looking at this basic column here for EMTs. This stuff is for advanced and paramedics. You want to give epinephrine if available. So if the patient has an EpiPen, go ahead and administer to them. And we're going to go over that in the next slide as well. You want to give 25 to 50 of Benadryl if possible, if indicated. If they can swallow, great, give it to them. If not, we can have a paramedic give it to them IV. The albuterol, again, if they're if you hear wheezing in the lungs, you're going to want to administer albuterol, trying to open up those lungs and try and get that patient breathing a little bit better. And then over here in the severe category, it's pretty much the same thing. The only thing they add is the airway protocol. Like I was saying, you just want to make sure that airway stays open. So with an EpiPen, a lot of patients will have these, especially like I was saying, if they know they have a specific allergy to something. So with these are really simple to use. A lot of the newer ones even talk to you and walk you through it. So you're going to pull this blue cap off here. You're just going to pop that off. And then this orange side here, that's going to go towards the patient's thigh. I cannot stress this enough. This is not a button. Do not press this because the needle will come out of this hole right here. And if you push it like a button, the needle's going to go right in your thumb. It's not going to lead to good things. So you're going to want to push this into the patient's thigh. You'll hear it click, and that's what that means, that the needle will come out and the medication is being released into the patient. So you want to listen for that click, and once you hear that, you want to hold for 10 seconds. So pretty simple to use. Again, like I was saying, a lot of the newer ones I believe will talk and tell you what to do, so they're pretty dummy proof. But it's always good to know what you're doing with these, even if you don't have the ones that talk. So we'll move out of anaphylactic and go into obstructive now. If you see any causes of obstructive, go ahead and treat them. A lot of those can't be taken care of at the EMT level, so not too much to worry about. But again, you might want to call ALS. If you see a tension pneumothorax at the ALS level, you can decompress the chest. But again, not too much to worry about at the EMT level there. Again, with this, though, rapid transport, they need a hospital more than they need us, so get them there as quickly as possible. And you want to monitor and reassess frequently. That's the biggest thing. A lot of the new monitors have the functions where you can get the blood pressure to cycle every minute. I would recommend that, or maybe even 5 minutes, just to get a good check. Make sure everything is going the way you want it to go. And just monitor your patient. Treat the patient, not the monitor. That's the thing that we learn a lot. We want to make sure that we're treating what the patient shows and not what the monitor shows. So I got a nice little graphic here with some of the types of shock that we went over. So with anaphylactic, you're going to see respiratory rate can vary. It can either be high or low. You're going to see high blood pressure, high heart rate, low blood pressure. Skin's going to be flushed, swollen, maybe itchy. No temperature change. Urine, we're not going to really care about that. That's going to be more of a nursing standpoint. And then other signs and symptoms, you can read that for yourself. With the temperature, a lot of these are going to say no change. Obstructive, you're going to have a low temperature. Neurogenic can be either way. And then septic, like I was saying, with that specific range that you can see. So yeah, that's going to be it. Again, this chart is very helpful if you want to go ahead and take a picture of that. But that's going to be it for today. Thanks for listening. Hope everyone learned something.